You are watching AHA Heartbeats, where knowledge is science in progress. I'm Javed Butler, Chief of Cardiology and Co-Director of the Heart Institute at Stony Brook University in Stony Brook, New York. I serve on the Clinical Council and the Heart Failure Transplant section for the American Heart Association, and I have had the distinct pleasure of also serving as a writing member of the ACC, AHA, HFSA heart failure guidelines as well. So I certainly carry this dual burden of making sure that our patient gets the best care and all the guideline recommendations are implemented, not because only that I'm a cardiologist and my practice is actually focused primarily on heart failure patients, but also as a co-director of the Heart Institute and the Chief of Cardiology. In a way, it is sort of my responsibility to look and make sure that patients who come into the hospital or our outpatient clinics, that we have systems in place by which they can get the best possible care that is available for the patients out there. So it's not only a personal connection for me one-on-one with the patients where I am the treating physician, but also perhaps working with my colleagues to come up with systems of care that can improve care for all the patients that come through our healthcare system. So, historically, we have sort of thought that our work is done once we do science. We come up with positive results. The regulatory agencies look at the data, and then if it's safe and efficacious, the drug gets approved or the device gets approved or whatever the care is. And then a bunch of people who spend a lot of time thinking through the diseases and therapies come up with guidelines recommendations, and that's where we stopped. And we said, well, the guideline recommendations are made, and that automatically this will translate into good care. Well, what we have learned historically is that it takes a long time by the time the guidelines come out to those therapies that are being widely used in the community setting. I mean, there are some estimates that suggest that it may take 16 to 17 years by the time that happens. So certainly the work is not done. Guideline is an incredibly important initial step, but it is an initial step, and there is a lot more that needs to be done. So clearly, empowering our patients. I sort of say to my trainees that I'm the coach, but the patient is the player, so the patient has to play the game. So empowering the patient and just writing a prescription and giving it to the patient is not really empowering the patient. I mean, they need to understand why they're taking something, what are the side effects, what are the benefits, and then also giving them the tools by which they can actually continuously use the therapy and be compliant and adhere to the therapy and not miss the therapy. So that is sort of the patient side of the equation. But on the healthcare side also, I mean, we live in really integrated healthcare systems. Everybody have their sort of different roles, and those roles become even more important as we are asked to see more and more patients in a relatively limited amount of time. There is a lot of things that we need to address. So I think physician's role is obviously critical in providing optimal care, but so is the team. So it's not only the physician, it's the nurses, the nurse practitioners, the nutritionists, the pharmacist, the exercise therapist. Everybody sort of really combines together to turn the patient around. Patients with heart failure have a whole plethora of issues that they're dealing with. So a doctor may know everything about a particular drug, but may not know everything about sodium or potassium or what diet to take. So they need to go to a nutrition. They may know everything about the side effects of the heart failure drug, but they may not know the side effects and the drug interaction for all the other 10 medications that the patient is taking for their other comorbidities. So they need to go to a pharmacist. So I think that we need to think broader than the doctor-patient interaction, which again is critically important, but think broader into systems of care and how across the spectrum from inpatient to outpatient to different specialties can we take best care of our patients. Yeah, so in order to sort of create these systems, there are again a whole bunch of tools that are available outside that we can reach out to. Some of them are basically educational tools, so you can have your staff go through CME, whether the CME lectures are or CNE or other accredited lectures. They can be at your institutions, or you can have people go somewhere to get that, or maybe even online, but that is just to educate individuals. Then you can have sort of homegrown processes, so you can have care pathways and order sets and other things that can make sure that you're providing really good care. But I think one thing that also really helps is to get involved in national initiatives, national quality improvement initiatives by professional organizations, American Heart Association, American College of Cardiology, other professional organizations for different disease states. There are quality improvement programs, there are registry programs that can really tell you how your real performance is. I think one blind side that we all have as providers is that we feel that we always give perfect care. And the reason why we don't necessarily always give perfect care is not because we don't know how to give good care, but because there are so many things happen that you miss out on the opportunity. So having those data, and then not only data for your own institution or your own practice, but comparative benchmark data from other like institutions really gives you, one, your sort of competitive juices to start flowing a little bit, but also gives you an opportunity to objectify, to quantify where the deficiencies are and have targeted interventions as opposed to generic interventions as well. So I think between the educational opportunities, between the quality improvement opportunities, between opportunities looking at the data, and then all patient focused opportunities as well in terms of patient education, not only the professional education, I think we have a lot of tools. The issue is not whether or not we have tools to improve care. The issue is, are we committed? Is our institution committed? And whether we are going to just take the step to make it happen. So I think the tools are there. Implementation of the tool is up to us. So, patient engagement is obviously incredibly important. So let me just give you sort of one example of where I think as a system we fail. So if you have a patient with cancer who is completely asymptomatic, maybe running a marathon or whatever, and if you do a PET scan and the PET scan lights up anywhere in their bone marrow, in their liver, or in their lung, everybody appropriately would be really, really worried that there is residual cancer, you need to do something. When you come to a disease like heart failure, somehow we have transformed heart failure from a medical organic disease into a symptomatic disease. So what ends up happening in our clinics, very commonly seen, that patients come in, you just ask them, are you doing okay? We don't quantify, we don't define what okay means. We say, are you doing okay? The patient may say that they're doing okay. And then you just say, well, you know what? You're not necessarily on optimal doses of beta blockers. You're not on optimal doses of other medications. You don't have your defibrillator or pacemaker, but you know what? You're doing okay. I'm just going to sort of leave you alone for the time being. Now, the patient does not come back and challenge you because we have never educated the patient that there's really no low risk heart failure patient, that we have to optimize care irrespective of the symptoms, that the risk of sudden cardiac death is really there if we don't optimize patients' therapies. So those are kind of the things where educating the patients will do two things. One is that they will become partners with us as opposed to passive recipients. They will partner with us to ask us for better care. They will be more tolerant to what is required to get optimal care, because you cannot do optimal care without perhaps more frequent clinic visit or perhaps more blood draws and stuff like that. But once they understand why you're doing this, then that will be their engagement. And then once they are out of the interface of doctor-physician, doctor-patient or the nurse-patient interaction, and they are home alone and they're sort of doing okay, that's where this whole thing is really put to test, whether they keep taking the medication, keep eating the right food, keep doing the exercise, and until they really understand, it will be very, very difficult for them to do. I again sort of tell my students one thing, is that if our patients were to do just one thing, our life would be easier, and that is to get sick before, unfortunately, they die. Because if that was the case, you can say, well, you know what, you're doing okay, so when you start getting sick, I will start changing the medication. But that is just not the case. We have known over and over again that a good 40% or so of the patients with heart failure who die of sudden cardiac death, and it does not have to proceed with worsening symptoms or hospitalization. So really educating the patients of why they need optimal medical therapy and taking the burden on ourselves to optimize the therapy irrespective of the symptoms is really imperative.